members here, and I am very happy to be in this podium because I did my MBBS here, and to give a talk in the presence of my teachers and friends. I am very happy here. Thank you very much, Radha Lakshmi ma'am, Venkatramana sir, for giving me this opportunity. The previous speaker ma'am has covered important points, manual perineal protection, which will cover some points I will cover. So coming to the injuries to the parturient canal, the classification of the, so in this talk I will cover regarding the classification of the injuries, diagnosis, management, and how to save the perineum during delivery. Factors associated with the labor includes the anomalies of the passage, forces of the labor, and the passenger. So injuries are classified under two headings: injuries to the bony parts and injuries to the soft parts. Injuries to the bony parts usually to the symphysis pubis, to the sacrococcygeal joint, sacroiliac synchondrosis, fracture of the sternum, ribs, and vertebra. And coming to the injury to the pubic symphysis, it may occur spontaneously during forceful contractions during the delivery of the fetus, or sometimes it may occur morely in the assisted delivery when we are applying the outlet forceps. So diagnosis can be made with the history, where the patient gives a history of something giving away at the time of delivery, and obstetrician can also feel a grating sensation because of the snapping of the cartilage. And the gap will be felt between the pubic bones. The tenderness will be there on pressure. Pain will be felt more prominently on movement of the limbs. So here treatment mainly is the immobilize the joint, rest in a firm bed with adhesive plaster for the whole pelvis, and she is allowed to move after 2 to 3 weeks. Coming to the fracture dislocation of the coccyx, it occurs during the extraction of the fetus, where the subpubic angle is narrow and the fetus more tries to deliver posteriorly at the outlet. The condition is recognized some months after the delivery, and the patient complains of pain mostly in the sitting position in the lower part of the sacrum. The diagnosis is made by the palpation of the unduly mobile or displaced coccyx and persistent neuralgia called as coccydynia, and here the treatment is excision of the coccyx if the pain is very severe. Injury to the sacroiliac synchondrosis, it usually occurs after pubotomy, where the pubic symphysis gives away spontaneously during the process of delivery. Here the patient is unable to move the limbs freely, and patient complains of pain in the region of the sacrum. The treatment lies rest in the bed and proper support to the pelvis by strapping for 2 to 3 weeks. Coming to the injuries to the soft parts, injuries to the vulva, vagina, and lacerations of the cervix, hematomas, calporexis, injury to the bladder, ureter, and urethra, rupture uterus. So injuries to the vulva, they are very common. Slight tears of the labia minora, fauciata, or vestibule. Minor lacerations may not require treatment, but lacerations of the vestibule where it causes severe hemorrhage that needs suturing. The lacerations of the vagina are more common because of the forceps delivery or in breech delivery. In forceps delivery, where we try to rotate the head artificially with the help of forceps, or when we apply the forceps, when it slips, the trauma will be more. And the separation of the pubic bones or pubic symphysis giving away. More severe form of lacerations will occur when the head is jammed in the pelvis for a long time, which may lead to fistulous communication with the bladder and rectum in the later part. Vaginal tears may be either longitudinal or transverse, involving the fornices. Sometimes it may also extend into the pelvic cellular tissue. The chief danger of vaginal tear is the infection, and slight lacerations heal spontaneously. Extensive lacerations, we have to suture it. Next, coming to the lacerations of the cervix, the rapid delivery of the head by natural forces or by the assisted delivery when the cervix is not completely dilated, here the lacerations will occur. Serious injuries usually occur with the application of the forceps when the cervix is not fully dilated. And the third cause is the rigidity of the cervix, which may be due to natural cause or because of the disease, and in the elderly primate also cervix will be rigid. Another complication is the circular tear or avulsion of the cervix or annular attachment of the cervix, where it occurs when the cervix is nipped between the presenting part and the application of the forceps, and when we give a traction, the whole rim of the cervix will be avulsed. That is called as annular attachment of the cervix. And here in the small tears of the cervix, they heal without difficulty. Large tears usually cause traumatic PPH. For any postpartum hemorrhage, when the uterus is hardly contracted and when there is a fresh bleeding, we have to definitely expose the cervix for traumatic postpartum hemorrhage. Here is one case scenario. A 24-year-old primary semigravida. She was referred from nearby PHC for failed progress of labor. So on taking the history, she gives a history of prolonged labor. On examination, GC was pallor, she is irritable, BP was 90/60, her pulse rate was 130, per abdomen uterus was tender, fetal heart was absent, and on vaginal examination, hot dry vagina present, presenting part high up and caput was present. Here emergency LSCS was done, interim findings were hemoperitoneum with hematoma was there. Here the history which they did not give, and later we have found is they have tried the forceps application, later she was sent. So the cervical tear, it has extended into the lower uterine segment involving the uterine arteries, and it also extended into the peritoneal cavity, and there was a hematoma. So more severe lacerations, they may manifest as an external hemorrhage or a hematoma. So diagnosis here was a cervical tear, and she presented with a profuse hemorrhage during the third stage of labor. So thorough evaluation is needed in every case of a outlet forceps application or any difficult delivery. So the extent of injury fully appreciated with adequate exposure and visual inspection. But accomplished with when assistant applied a firm downward pressure on the uterus, the operator exerts a traction on the lip of the cervix, the tear can be visualized. The cervical laceration of 2 centimeters less than did not be repaired, but deep cervical lacerations need to be repaired. The later complications of these cervical lacerations are extensive scarring to involve the vault, ectropia, persistent cervicitis, sterility, repeated abortions. Sometimes it may cause preterm labor, or it may lead to dystocia in the next pregnancy. Next, coming to the another complication, pupular hematomas. Here the cause for these hematomas will be lacerations, or it may be because of episiotomy or because of operative delivery, or rupture of the blood vessels without associated lacerations, sometimes associated coagulopathy. The one more classification of these hematomas is vulval hematomas, vulvovaginal hematomas, paravaginal hematomas, and retroperitoneal hematomas. The vulval hematomas involving the vestibular bulb, mainly branches of the internal pudendal artery, inferior rectal, perianal, and clitoral arteries. Paravaginal hematoma usually results because of the descending branch of the uterine artery. In some cases, the torn vessels may lie above the pelvic fascia, where it causes supralevator hematoma. These vulvovaginal hematoma, they develop rapidly, frequently, and they usually cause excruciating pain. Small, medium-sized hematomas where the bleeding ceases, it gets absorbed. Sometimes the tissue overlying the hematoma may rupture and it may cause pressure necrosis, profuse hemorrhage will be there. Sometimes hematoma may drain off to form the large clots. Sometimes they extend into the paravaginal spaces and also above the levator sling. Retroperitoneal bleeding may also be massive and extensively fatal. The diagnosis of these hematomas, rapidly diagnosed by the severe pain will be there. A tense, fluctuant, tender swelling of varying size rapidly develops over the discolored skin. The symptoms will be the pelvic pressure, pain, inability to void, should prompt the evaluation of these hematomas. So management depends upon their size, duration since delivery, and expansion. Small hematomas, we can go for expectant management, and if the pain is severe or hematoma continues to enlarge, surgical management is preferable, where we have to give an incision on the prominent part of that hematoma. We have to drain all the clots which are present, and if any bleeder is present, we have to suture it, and that the dead space also should be obliterated, and we can keep a pack for 12 to 24 hours. And supralevator hematomas, they are difficult to treat. I told you the vulvar and vaginal incision can be given, and a laparotomy is needed if there is a continuous hemorrhage. Blood loss with large purpural hematomas is nearly considerably more than the clinical estimate. So here the hypovolemia will be common, and the transfusions are frequently required where the surgical repair is necessary. Sometimes we can go for angiographic embolization when the surgical attempt at hemostasis failed and hematoma is difficult to access surgically. Use of Bakri balloon for paracervical hematoma can be done. So one case scenario regarding this vulval hematoma. So a 28-year-old woman, she is a second gravida paravan live one. She presented with labor pains, labor progressed uneventfully. RMLE was given. Few hours later, patient complained of excruciating pain over the perineum and she was irritable. And on examination, pallor was present, pulse rate was 120 per minute, her blood pressure is 90/60. So on examination, the hematoma was seen. That was the diagnosis of vulval hematoma. So the hematoma which may escape detection until it felt on abdominal examination or until hypovolemia develops. Here the staging CT is useful to assess the degree. Next, another complication is the colporexis. Here the rupture of the vaginal vault in labor, more common in the multiparous women with a good obstetric record, as the vault being the weakest point may give away usually in the posterior fornix. The signs and symptoms are here similar to that of rupture uterus. The management mainly is the laparotomy is the treatment of choice. At laparotomy we may find the cervicovaginal junction has completely given away and uterus could be attached to the vagina either anteriorly or posteriorly. Sometimes bladder may be involved in the anterior tear. So next, coming to the another important complication is the rupture uterus. This rupture uterus can be primary where it occurs without any scar. Secondary may be due to the scarred uterus. So the rupture may occur during pregnancy or it may occur during labor. During labor the most common cause is the obstructed labor. Direct trauma also causes, it may attribute to 1%, and obstetric operations and injudicious use of oxytocics or misoprostol also. So during pregnancy, it usually called a silent rupture. It may be complete or incomplete. The causes are the C-section scar usually gives away, usually situated in the upper uterine segment, injury to the uterus during previous pregnancy, difficult manual removal of adherent placenta, thorough curettage, perforation of the malignant mole, that is GTN, and spontaneous rupture may also occur in high parity, which is usually situated in the fundal region. Here the clinical symptoms and signs are often misleading because it will be insidious, so it's called a silent rupture. The scar gives away only when there is a maximum distension between 34 to 38 weeks, but it may also occur as early as around 20 to 22 weeks of gestation. Here the woman will be having the mild abdominal pain mistaken for labor pains, a slight increase in the pulse rate, further yielding gradual trickling of blood into the abdominal cavity. She will develop abdominal distension, vomitings. The amniotics are gradually escapes into the peritoneal cavity. Placenta also escapes. Next, the classical signs and symptoms of rupture. Now she presents with shock, collapse, and fetal parts easily palpable. Contracted uterus felt separately lying to one side. Here the treatment is laparotomy with the treatment of shock. Hysterectomy we can go if the patient is a multiparous woman, and also with the treatment of blood transfusions. For young women, we can go for excision of the edges of the scar with the bilateral tubal ligation. Next, coming to the rupture of the lower uterine segment scar, it is more common in labor. Here the woman complains of pronounced localized fullness and tenderness, suprapubic pain, bladder tenesmus, blood-stained urine. And another type of rupture is which occurs during the obstructed labor. It is the most common type of rupture. Etiological factors will be the CPD, malpresentations, cervical dystocia, hydrocephalus or grand multipara. The mechanism of rupture here will be the upper segment will be contracting and retracting, the lower segment will be stretching and dilating. So at the peak of uterine contraction, the lower segment usually gives away. Here again, the Mandel string will form. The patient will be anxious and agony and exhausted. The findings on vaginal examination will be hard, dry vagina with large caput. This stage is called as threatening rupture. So at this stage, when the help is not given to the mother may die because of again shock and hemorrhage collapse. So rupture due to obstructed labor usually will be the lower uterine segment. Sometimes it may also extend into the broad ligament. Rupture may be here incomplete or complete. In a case of incomplete rupture, we should have a suspicion of accidental hemorrhage also. So how to differentiate between accidental hemorrhage or incomplete rupture means depending upon the history, depending upon your examination findings, we have to differentiate whether it is an incomplete rupture or it was an accidental hemorrhage. Coming to the diagnosis of rupture, as I told, history of prolonged labor where the patient will be in a history of shock and collapse with hardly recordable pulse and BP, very easily palpable fetal parts, absent contour of the uterus. So the prophylactic measures what we can take here is early diagnosis and proper management of cephalopelvic disproportion. Extra care should be taken during the selection of cases for VBAC. So management lies here is treatment of shock and collapse, blood transfusions, and in a case of neglected shoulder presentation, go for emergency LSCS. Treatment if the woman is seen late after rupture. Here usually women may present few hours or 2 to 3 hours after the rupture. By the time she present you, she may be in a state of shock and collapse. Here important thing is we have to stabilize the patient. We have to rally the patient first, correct her vitals, plan for blood transfusion, and try to raise the blood pressure by 290/60, then go for emergency laparotomy. But even then also, if the mother is not improving, if the mother is not improving, simultaneous management of correcting the shock and also shifting the patient to the theatre. So only few points I will say regarding the how to save the perineum during delivery. Mainly it occurs because of the relative disproportion between the presenting part and the vaginal outlet, or when there is a too rapid expulsion of the presenting part and when enough time is not given for the stretching of the perineum, when the longer diameter of the presenting part emerges at the outlet. So we should mainly aim at to prevent too rapid expulsion, to preserve the normal mechanism of labor, to deliver the presenting part in between the pains. So here, as madam told, we should try to, with the non-dominant hand, we should apply the pressure to prevent sudden slipping of the head. With the dominant hand, we should apply the pressure. Method of protecting the perineum. Because saving the how to save the perineum depends upon the skill of the obstetrician and care given at the time of the delivery. Because if the care and not given at the time of the delivery, in the later life she may land up in stress incontinence, genital prolapse. All the gynecological problems will be related to the not properly managed delivery. Thank you all.
Thank you, Dr. Sreedevi, for